Good afternoon, everyone. I'm Katrina Moline, Executive Director of Hand to Hold, and I'm here to welcome you to our last session of the day. I hope everyone has had a great day so far with lots of valuable takeaways. It is my pleasure to be able to introduce to you today Dr. Sarah Wakefield, speaking about why improving mental health care is an ethical imperative. Dr. Wakefield is a board-certified adult, child, adolescent, and forensic psychiatrist, and additionally has training and expertise in reproductive psychiatry. She is currently chair of the Department of Psychiatry at Texas Tech University's School of Medicine and is active in providing psychiatric diagnostic evaluations and treatment planning for families, adolescents in the juvenile justice system, and for pregnant or postpartum mothers. Dr. Wakefield is dedicated to system improvement in mental health care delivery and to mental health care education. Dr. Wakefield, thank you so much for joining us today.
My pleasure. Thank you for having me. I'm excited to get to be here and talk with all of you about this. Thank you for being here. Yes, we're going to talk today about why improving access to mental health care is an ethical imperative, and in that way, really all of our jobs, but about some specific programs that are available in Texas and really in many, many states across the country now. That aim to do this by collaborating together across multiple different specialties. So next slide, please. Thank you, Nina, for advancing these slides for me. The next slide just tells us that this program is provided through the Texas Child Mental Health Care Consortium. I'll talk a little bit about what that is in a little while. I have no disclosures for you today. Next slide. So what are we going to do? What are our goals today? We are going to review the incidence of mental health disorders in youth and peripartum women, summarize the outcomes for untreated mental health disorders, describe access programs within the ethical constructs of beneficence, non-maleficence, and justice, describe Texas's CPAN and PeriPAN access projects, and then identify barriers to mental health assessment and treatment in your clinical setting. We're going to talk about what some of those barriers might be and have you think through how we could use CPAN and PeriPAN, these access projects, in improving access to care. Next slide. So goal 1, reviewing incidence of mental health disorders in youth and peripartum women. Next slide. So we have not really a comparison, but information here on the left about our youth and on the right about our peripartum women, rates of common mental health disorders. And many of you may know these as well. If you don't, I always think it's something that we should know. We should be sounding the alarm in our communities. Often I feel like warning sirens should be going off to remind us how serious this is for our community and what an impact it has. And also that these are linked, that these are things that if we take good care of mom, that can be very preventative for youth mental health distress. So thinking of these together makes a lot of sense. It is a good idea when we think about a population health perspective and in a prevention perspective. So 1 in 3 teens aged 13 to 18 has an anxiety disorder, which is about 30% of our kiddos. When we think about teenage girls, it's closer to the 40%. These are kids that their symptoms qualify for an anxiety disorder, not some worry sometimes or developmentally appropriate worry or a little bit of, worry about a specific thing, but this is that's time limited. This is the qualification for an anxiety disorder. And when you think about that, a lot of these teenage girls will go on to become moms. It is really imperative that we treat and screen and identify early what's going on and intervene early in this anxiety for our teenage girls. Less than 50% of young people reporting depressive symptoms ever receive treatment. And really, I don't think we have the slide on here anymore, but the standard or the typical delay in treatment for anybody presenting with mental health distress is 7 to 12 years. So when we think of, saying I'm having these symptoms, a lot of these conditions are presenting in childhood. That's when they first become symptomatic, but we're not diagnosing them until later, until adulthood. And we'll talk about this in a little while, but the perinatal period is a really important time for screening and diagnosis and intervention. And often, despite having symptoms for many years, the perinatal period is the first time someone gets screened and treated for their mental health condition. It probably comes as no surprise to you all that the isolation caused by COVID-19 pandemic did not improve our mental health distress. It actually worsened the mental health distress for youth and parents. And this last bullet point is really important for us to think through, that suicide is the second leading cause of death for youth starting at 10 years of age. And that is consistent up till about age 34. So you think the second most likely reason that someone is going to die in those prime peripartum years, childbirth years, but going down to starting as early as 10 years of age is from suicide. So again, really important that we learn how to screen, monitor, intervene, and support people through this trajectory for their mental health care. When we think specifically about peripartum women, 1 in 5 will suffer with a maternal mental health condition. So this is closer, when you think about that 20%, this is closer to what we see for adults across all categories, but is somewhat older data. And it'd be interesting when we look at that 40% marker for the teenage girls, some of that data is coming out post-COVID. So it is interesting to go ahead and look at these and to monitor for data in the last couple of years as well. Any of you who do research know that often we're getting statistics like these several years delayed. So that'll be something that'll be emerging right now. Less than 15%. So this is a much lower number of women in the peripartum period receive professional help. So if we're astounded by less than 50% of young people get treatment for the depression symptoms, less than 15% of women receive assistance and intervention for their symptoms when they're in that peripartum period. And there are lots of reasons for that, right? There are reasons that we're not screening, even though it's a standard of care. There may be reasons that when we screen, we don't know what to do. We don't have local resources, or we're not sure of what resources exist. There may be that even when we screen, that people aren't willing to tell us what their symptoms are because we have such a stigma in our culture around mental illness and mental health distress, especially for those women in marginalized communities where they have higher rates of peripartum mental health conditions due to lots of additional stressors, socioeconomic and just generational pressures, and often less access to care. Overdose and suicide combined are the leading causes of death for women in the first year postpartum. So I'll say that again as a reminder, and just to leave this here with these last 2 bullet points for both youth and for peripartum women, that suicide is a leading cause of death, both starting at 10 years of age and in that first year after delivery for women. And these are why I think we should be sounding alarm bells and talking about this a lot, decreasing the stigma so that we can improve access to care and improve willingness to come to care. Next slide. So one of the things we think about is that at least a lot of women are not getting care regularly, but they might get care. They're more likely to get care in this perinatal period. I don't know about you guys, but there are often times that I won't seek the care that I need for me because I'm so busy. But if my kid needs something, then I'm much more likely to go in for that. So this is the same kind of idea that when mom is pregnant, she's much more likely to seek healthcare than she might be otherwise, because she's worried not just about herself, but about her baby. Primary care clinicians and obstetric clinicians can expect, based on those numbers we just talked about, a significant number of their patients have or having to experience mental health distress, either in the past or currently. When we think about how high those numbers are that we just talked talked about. 20% of the pregnant population, 40% of some of our teenage population having diagnosable mental health distress conditions. Referring out this number of patients means they're often sitting on a wait list, getting no care at all. So I think we often talk about a mental health professional shortage, and we do have that across the country. We know we have that. But in addition, we refer out a lot of things that can be taken care of at a different level of care. And I think through this is clinicians, physicians tend to refer to physicians. I want another physician to weigh in on this and tell me what to do next. I want to make sure I'm getting my patient the best care. I think about patients that I've seen that have sat on a wait list to see me for months and months and months. And then I see and evaluate them and recommend an intervention like cognitive behavioral therapy that I don't tend to provide. And the reason I don't provide it is that there are lots of other clinicians in the community who can do that and do that well. And so then I'm having someone who has sat and waited for me for a really long time. I am then telling them, yes, you have depression. Yes, it needs to be treated. I do not recommend a medicine at this time. I recommend a cognitive behavioral therapy, and now go sit on another wait list to access this care. So this is the I laugh a little bit ironically when people talk about a system of mental health care, because it's the system often that we're talking about, which I don't feel like is a system of care at all. It's a disjointed mess. And that we're asking people often in high stress times when they're having symptoms, when their anxiety is high, to try to navigate this and know what they need. Even if there is no wait list. So if you live in some magical land, which I have heard of occasionally for a short-lived time, right? A new clinic opens up, they have availability, all of a sudden I can get someone into clinic. And so if there are these times that you can get someone into care, but even when there's no wait list and you can get someone into the care that you recommend, a significant number of patients don't ever go. And they don't go for a couple of reasons. One, they don't go because of the time commitment. They have lots of things going on. Now they're, especially when you think about the pregnancy period, they are now going to their OB appointments. They are going to potentially high risk OB appointments. They're doing other monitoring, maybe other things that they need to do for other children that they might have. And then you're saying, here's another appointment. You need to go somewhere else as well. Outside of your house, taking the baby, all of those different things and how complex that is. The other reason that they don't go is because of stigma. Because I don't know what's going to happen if I go there and tell this person, especially if I just had a baby. So I just had a baby and I go and say, I'm not sure I can take care of this baby. I'm not sure that I want to take care of this baby. I don't feel bonded with the baby. All things that are not that uncommon in the postpartum period, but that we don't talk about very commonly. I'm very overwhelmed with the baby's needs. They were not what I expected. And they, and it was causing me distress, or I feel like a failure as a mom. All these things that we know, if you've been a mom, or if you have a friend who's been a mom, you might know that those are not that uncommon feelings in the postpartum period. A lot of second guessing of yourself, especially if you don't have a community around you. But if no one's telling you that those are not uncommon feelings, who wants to go tell somebody that? And they might think, especially if they are from a community that has over time felt marginalized and not listened to in the medical community. They say these things, they might be afraid of CPS referrals or other such things, or just being viewed in a negative light. So there are lots of reasons that even when there is access, that our moms don't seek care, even when they feel like it could be helpful to them. Next slide. So goal 2 is to summarize some outcomes for untreated mental health disorders. So let's talk about what happens when we leave all those things we just talked about, all of those horrific, really, statistics about how many people are suffering and how little care is actually being sought and delivered. What is happening? What when we do nothing? Next slide. So you can imagine it doesn't go super well for our community. So for youth, we have evidence that we have increases in mental health emergency room visits, hospitalizations for children related to mental health increased 26%, really in the last decade, or the last decade that we have data for. Increase in substance use in youth, increase in school refusal and drug dropout, and increase in suicide rate. When we think about peripartum women, we see increased smoking and substance use during pregnancy and postpartum. Really, that goal is self-medication, self-treatment, trying to alleviate some of the suffering. Preterm delivery, low birth weight, and increased NICU admission. And lots of people have postulated why this is, and there's ongoing research around this. And some of it is a decrease in access to all care. I'm not going to any of my care, so I'm not getting other conditions checked out. But I think it's also really important to talk about that depression and anxiety and trauma are inflammatory conditions. And they're inflammatory to all areas of the body, including the brain. And when we leave them unchecked and untreated, we are leaving bodies in a hyperinflamed condition. And that is going to predispose to additional illnesses, additional complications as an independent risk factor, even if they are accessing care. In the postpartum period, we often see lactation challenges and bonding issues. And some of this could be my milk won't let down. I'm anxious. And so it's hard for me to go through that bonding process. I'm so worried about baby that I can't relax and enjoy when baby smiles at me. So I'm not even aware of these cues, of these reactions that are happening with baby, or these interactions that are happening and available to me, because I'm so worried about, are they well? Are they ill? What do I need to do? This is overwhelming. How am I going to take care of myself and this other baby? And also untreated mental health conditions, maternal mental health conditions, have multi-generational consequences. I often think there's a slide that I love from McPat for Moms, and it has this multi-generational focus where we look at the very first, like, generation zero, which none of us are. We've never met anybody who's a generation zero, but the idea is that generation zero individual did not have any stress coming into this world, did not have genetic loading for anything, didn't have genetic loading for any health consequences or mental health consequences, really was genetically without epigenetic markers as well. If we could talk about what epigenetic is, if that could be helpful to people, but those responses of your genetic code to the environment over time, we know that those markers get internalized in your genetic code as what we call epigenetics, and those are also passed down over time. So when you have this generation zero, the idea is you've never been traumatized, your genetic code doesn't have anxiety or depression or any of those things in it. And then something happens, right? You have a negative experience, you have a trauma, you have something happen to you, and that changes your genetic code with those epigenetic tags. That gets passed down to the next generation. Then that makes the response to environmental stressors different. It makes you more predisposed to certain illnesses and those kinds of things. And then based on your response and your ability to interact with the environment, you get additional epigenetics on to your next generation. And so when we think about many of the patients that we're taking care of, and just the people in general who are walking this earth, are generation 6, 7, 8, 9, we are carrying lots of epigenetic load over time, and that changes the way that our bodies and our brains respond to the environment. And then we're having our own life experiences with trauma and stress and financial difficulties and all of those different things. So sometimes it is ironically funny to me when people say, oh, these two people had the exact same experience and they responded differently. And I think, we're minimizing the effect of epigenetics. We're minimizing the effect of that peripartum period of what was that in utero experience that we can't see, that we don't walk around on our sleeves and say, this is what happened to generations before me. This is what happened to me in utero. That is something that we can't see, but is a living thing that really affects all of our experiences and what we go through. So over time, we see maternal mental health conditions having multi-generational consequences, cognitive delays, motor and growth issues, behavioral problems, and mental health distress in offspring. Lots of evidence that things as simple as mom talking in a sing-song voice to baby. I had a sick kiddo here today, And he ended up being just fine, as they do, that they look terrible in the morning. But I brought him here with me for a little while today. And, everyone in the office kind of looked at me funny because when I'm interacting with my baby, I have a different voice. I talk in a different cadence. And I don't notice I do that. I don't mean to do that. It's just the way in which we interact. And that's normal. That's biologically encoded into us. And doing that, processing life aloud in a sing-song voice is actually really important to the way a baby's brain develops. And so if mom is depressed or mom is anxious and she's not doing that, or she's processing in a way that is not a sing-song voice and it's overwhelmed and those kinds of things, that's changing the way that brain is developing. It's changing the way the amygdala, that fear center in the brain, is perceiving the world. And those are all things that we're not teaching moms. We're not teaching anybody about how very, very important this peripartum and this perinatal period are. When we look at untreated maternal mental health conditions, and I think this is a woefully low estimate because it's not taking into account many, many of the things we were just talking about, but it does cost Texans about $2.2 billion a year when you look at all of the costs associated from conception to 5 years postpartum of not treating mom and how both mom and baby are doing over that time period. Next slide. So the outcomes of untreated mental health distress in peripartum women and youth are devastating. I think if we don't, even if we're not focused just on the horrific statistics around suicide in this population and overdose, when we think about the compounding impacts to child development and babies, and really those impacts of mom, of all of those missed years, and not just of work productivity and engagement in community, but really getting joy and being able to experience the growth of their baby. And this is a public health crisis that we must all work together to address. And in that way, it's an ethical imperative that we help identify those who are suffering. So first, we got to find out who it is. We got to make it okay to say. We got to say, if we really have to be culturally appropriate in the things that we are doing and screen in places where people are comfortable, and not just when we send them to a psychiatrist or a mental health clinician, but where do we screen? Where do we talk about this? How do we make it okay to say and okay to screen so that people can tell us how they are doing? And how can we screen at regular intervals so that we are not missing people and we're not missing the development of these symptoms? And then we need to provide them care that helps them achieve wellness, which is different for many different people. What different people need depends on all the things that we've been talking about. How did they come into this world? What is the lineage? What is the history of their genetic code and their epigenetic tags and all of those things? What traumas have they experienced and what supports have they experienced in the meantime? And so really thinking through what that care is to help each individual achieve wellness. Next slide. So we're going to describe some programs that have shown to help us do this. And they, like most great solutions, are not rocket science. They were a good idea that really is showing over time to have a phenomenal impact in improving access to care, lowering the stigma in getting access to care and in screening, and trying to get people well in a system of a community. So we'll do this within the ethical constructs of beneficence, non-maleficence, and justice. And I think it's important to describe these constructs just a little bit, but we'll go to the next slide first. So I'm going to talk about the history of access projects to improve collaborative care. So thinking through, we talked about there's a mental health professional shortage area. If we talked about the large number of individuals, both youth and children, who have mental health distress and qualify for some diagnosis, if we referred all of them to a mental health professional for care, we would have 12-month wait lists. Guess what? That's what we do. And we're not even referring everybody, right? We have very low rates of referral when we think about the 15% or the 50% of patients. So we're not referring everybody, and we have really long wait lists. So what do we do? How do we work together? How do we collaborate to provide a higher standard of care? And some folks in Massachusetts said, let's try something new. And really, that's not new. That's something that we've been doing in the healthcare community for a really long time, but let's operationalize it. So in 2004, Massachusetts decided to start a pilot project where they said, we're going to call it the Massachusetts Child Psychiatry Access Project. We are going to provide basically what we call in the medical field a curbside consult to those people who are trying to take care of children. This started with children with mental health distress in their office. So they're not sure what to do. They're not sure what screener to use. They're not sure how to counsel or guide parents when they come in with different questions. So instead of just having that experience happen in the primary care setting, and then some referral to go to Never Never Land, to sit on a wait list, and then wait for that kiddo to get a response from a clinician when they have an opening in the future. We're going to start a hotline. And a child psychiatrist will be available 8 to 5, Monday through Friday, to answer anyone's questions. When they say, what is, all of those things. Someone may come in, someone may call, someone may be there for an appointment. It may be a question from a parent, maybe a kiddo who really looks down, but is telling you they're okay and not sure what to do or how to proceed. We're going to provide a child psychiatrist to counsel that primary care clinician and answer their questions. This is a format that we've had in medicine for centuries. I mean, I imagine as long as medicine has been around, where if someone needs help from their colleague, the first thing they do is call them and say, this is what's going on with the patient I have, and I'm not quite sure what to do. And in that clinician to clinician discussion, they reason through things. There's some exchange of knowledge. We talk about what has worked, what hasn't, what have you tried, what are next steps, what's the evidence base, and those kinds of things. And that conversation could be 5 minutes, it could be 3 minutes, it could be 20 minutes, it could be 25 minutes. But you have a conversation with a clinician colleague. So that is what the MCPAT program started, was the primary care clinician could call a child psychiatrist and have that conversation. I'm not sure. I'm not really comfortable screening with a kiddo this young or starting a medication without some guidance. Can we talk about what standards of care are? Yeah, great. Let's do it. And it was wildly successful. And so due to the success of the MCPAT program, it was expanded to support clinicians treating pregnant and postpartum women when it was called MCPAT for Moms in 2012. And the idea is the same. Mom comes in, I'm not sure, pregnant, postpartum, planning pregnancy. Mom has these questions, not sure what to do. She's been on this medicine. Is this a safe medicine to stay on? Is this a dangerous medicine to get off of? How do I counsel her? I didn't receive this exact training and residency. But I want to do the right thing, and I don't want to send her to a wait list to nowhere, bridge to nowhere. I think this is really important. I know how important this is to help mom and a part of the care of both mom and future baby. And so that is the MCPAT for Moms program. When we think about what has happened since 2012, it's pretty amazing because these programs have spread across the nation. They are typically state-based programs. There are a couple of programs that are states in a compact together because their populations are so low and they have lots of rural area. But overall, these are state-based programs where the legislature or HRSA, there's grant funding, or the legislature of that state has said, we want to provide this hotline access to that frontline clinician so that we can keep their care in that clinical setting where they're already comfortable. Next slide. So some outcomes, when I told you it has worked. We've seen some great evidence associated with this when we think about outcomes when collaborative care access project models are implemented. We see in our youth model, so that original MCPAT model, that high rates of parent satisfaction with PCPs who utilize the service. So they weren't being put on a wait list and sent somewhere else. Their PCP, who they trust, many of times they've been seeing this PCP since the baby was very young. they trust PCP, and the parent says, wow, yes, you were able to give us additional information. Thank you for calling this line. And so high rates of parent satisfaction in that PCP office. We also have seen that it strengthened the relationship between the PCP and the families, that there was an increase in bonding and relationship building and rapport building there, an increase in trust in that primary care relationship. It enhanced the ability to deliver mental health care consistent with family preferences. And so thinking through that PCP having the cultural lens and of the clinic that they've been in for a long time, and the relationship with this family, that they were able to listen to the psychiatrist, get various options, go back to the family and talk about which ones might work for that family. And so utilizing a line like this increased our cultural kind of empathy, I guess is a good way to say that, cultural humility around that not all of us are interested in the same types of treatments, have the ability to do them, and that having the family be a part of that process and a part of that discussion is very important. So we could start a medicine, I'm thinking of a conversation like in youth, when we think about anxiety, there are multiple studies that show us that a medication like an SSRI is equally as effective as a cognitive behavioral therapy intervention. And so we can have that discussion with the family. Which one of these why would I send you to a psychiatrist to wait on their wait list if you really, if you understand that they're equally as effective and you'd like to try therapy first, let's just send you there. So really engaging the family in that discussion as early as possible, and then referring them to the right level of care. So they're not, like I discussed earlier, sitting on a wait list for a really long time and then being told to go to a different wait list. And then the PCP applied knowledge that was gained in previous calls to subsequent patients, which is really the crux of the Access Project, that we're building capacity in that frontline clinician, that they say, you know what, now I've done this. Now I've talked to someone 2 or 3 times about this presentation. I feel confident. I feel much more confident in what to do next and what the standards of care are. And so when we looked at the peripartum or the MCPAT for Moms program, there was clear information that over time, the call volume of these clinicians to call the hotline didn't shoot up. Once it reached a certain level after everyone was enrolled, it stayed about the same. But what did change were the complexity of the calls. So now the PCPs, though, for frontline clinicians, the obstetricians, were feeling much more comfortable with the standards of care of things like straightforward depression and anxiety, and people were getting treatment much more quickly, but they were calling for more complex health needs, which was really exciting because we could say, well, now I can provide you some guidance around this. But what it really, really does is it means that all of those people aren't sitting on a wait list for all of those services. So the women or the youth that they're calling about now who have more complex health needs, those wait lists are shorter. Right? There's not as long of a line to get to that service. So in that way, it also increases access to care, to the right level of care at the right time for the people who need those different levels of care. In our peripartum population, we've seen that it's feasible, acceptable, sustainable approach to increasing access to evidence-based treatments for perinatal mental health and substance use disorders on a population-based level. Very much because of the things that we've already discussed. And I think another thing that is really important is thinking about, this is a very low cost approach. This is not hiring hundreds and hundreds and hundreds of new mental health professionals. This is not waiting until we've trained hundreds and hundreds and hundreds of additional mental health professionals. This is utilizing, I can sit in one office with a team, a small team, and answer questions from docs all over, clinicians all over the state. And one clinician may have one question, but I can answer their question, and then I can answer a question from another person from a different area of the state, back to back to back. So when we think about, we do have evidence to support these interventions, that they work, that they improve satisfaction of the patient and the PCP, they improve rapport, and they improve outcomes. I think one of the things that was the most interesting to me was some of the data that calling a hotline, calling an access project, and retaining that care when appropriate. It's not always appropriate, but retaining that care in that frontline clinician's care setting actually, for many and most patients, improved their outcomes compared to if you sent them to a psychiatrist or a mental health clinician and sat them on a wait list. And why? Because of those things we talked about, because there's a long wait list. And also, even if they don't have a wait list, they might not show up to that treatment, but they're much more likely to show up to these other appointments that are built in, that are very low stigma in our society, right? Your well childs or something everybody does. You have a sick visit, go see your pediatrician, go see your PCP, prenatal health care. So all of these things that are destigmatized and supported in our society, we want to screen and deliver care in these settings to help work towards that destigmatization of mental health distress. Next slide. So beneficence, we're going to talk a little bit about the ethical constructs that are important here. So beneficence is the ethical construct that we want to do something good. We want our intervention to bring good, is the idea behind beneficence. And in that way, our access projects fill gaps. They build capacity to support the mental health of youth and perinatal women. They improve outcomes, as I just talked about, and it reduces stigma. So we're bringing good for, through these access projects. And next slide. The concept of non-maleficence is that we're not adding bad, that we don't want to do something that creates a bad outcome. We want to bring good. And so these are very tightly linked, but they're a little bit different. And one of those things is that this does not delay care or send patients on a resource bridge to nowhere that I was talking about. I love this quote from one of our PCPs who helps us with these projects. You wouldn't let an asthmatic wheeze for 6 months while waiting on a waiting list, right? Everyone would think that was complete malpractice. We wouldn't watch someone suffer and say, oh, you still haven't been seen. I can't do anything to help you. We'll just wait until you're seen, which is what we do for mental health care, what we have done for mental health care all of the time. Next slide. And then the last one is justice, this concept of justice, ethical concept of that. So we want to ensure that we are providing the right level of care at the right time. When we talked about, physicians tend to refer to physicians, people would be on my wait list and I would go see them and they're not getting the right level of care. I really never needed to see them because another treatment was the right treatment for them. Well, now not only have they not gotten the right treatment, someone else who needed the treatment that I can provide was denied an appointment because that was being taken by someone who didn't need it. So the idea of justice in these programs is that people are more likely to get, now it's not perfect, no one's perfect, but they're more likely to get the right level of intervention that they need for the symptoms that they are having sooner. Because we've seen that these projects reduce wait lists so that youth and women with more complex diagnoses and symptoms can get into a higher level of care more quickly. Next slide. So I'm going to talk to you a little bit about what Texas's CPAN and PeriPAN access projects look like. We talked about why we have them, why there's a problem, what impact that problem has on the health of our communities, why access projects are a good idea, and what evidence we have around access projects. And now we're going to talk about what we're doing in Texas through CPAN and PeriPAN to help achieve these goals of beneficence and non-maleficence and justice, getting people the right level of care at the right time, building capacity in those frontline clinicians. Next slide. So this story starts before 2019, but a good place to start is 2019. The state of Texas is clear that we are in a state of urgency around mental health and that this is a population health issue we must work together to address. And prior to 2019, the UT system started gathering the chairs of psychiatry across the state of Texas, first in the UT system, and then very quickly the rest of the chairs of psychiatry, with the goal of coming together to advocate for improvement in mental health access and care in Texas, knowing We were at the bottom of the list when you looked at nationally at states. And we don't lie. I mean, I'm a native Texan. Nobody in Texas likes to be last at anything. And so we said, how can we utilize all this expertise that we have in the state of Texas to help improve access and care? And so we started meeting together as a group of chairs of psychiatry. We started talking about researching programs that do work. The Meadows Mental Health Care Policy Institute was integral in this, as were some wonderful folks from the population health initiatives in the UT system, really looking at what can we do to improve access and improve evidence-based care in Texas. And in 2019, that group of chairs and a few others was codified into law, the Texas legislature, when the Texas legislature created the Texas Child Mental Health Care Consortium. And the goal was to improve support for primary care clinicians through an access project. There are actually several goals. I'm not going to go into everything that the consortium is doing, because it could be an entire lecture itself. If that can be one of the questions, I'm happy to answer that later. But when we're focused on Access Project, this was one of the large initiatives under the Texas Child Mental Health Care Consortium, because we saw how it worked in Massachusetts. We know Texas is not Massachusetts, but we wanted to take evidence-based interventions, evidence-based population health initiatives that have worked in different states and worked around the country, and see how can we support Texans similarly. So we called it CPAM, the Child Psychiatry Access Network. And we started that program. Dr. Laurel Williams is the medical director of that program. It is, and I'll talk about the tenants, but it's a hotline, like I described before. The child psychiatrist, just like McPap, the child psychiatrist is available. The pediatrician or family medicine doc or other frontline clinician says, I don't know what to do with this kid. I'm concerned about him, but help me. And so we started that project. And in 2020, the Texas Maternal Morbidity and Mortality Review Committee said, we need to improve integrated behavioral health care access from preconception through postpartum for women with mental health and substance use disorders. So we started talking initiatives in Texas where we're trying to do this. So this is not the only one, but one that seemed like a no-brainer was to expand the population being covered by a project like CPAN, just like Massachusetts did in the past, to a project that also covered and provided reproductive psychiatry, reproductive mental health expertise to pregnant and those clinicians caring for pregnant and postpartum women. So in 2021, the Texas legislature voted to expand CPAN services to serve clinicians seeing pregnant and postpartum women, and we called it PeriPAN, Perinatal Psychiatry Access Network. Next slide. So thinking through the original structure, there are 12 state-funded health-related institutions of higher education. So mouthful, what that means to, I would say lay people, but even to me, I was like, what is an HRI? It's what we typically think of our health sciences center. Not every single one is named a health sciences center, but most of them are. So a lot of like at Texas Tech, we have Texas Tech University, and then we have Texas Tech University Health Sciences Center as another component institution for the larger Texas Tech system. And so there were a makeup of 12 of those health-related institutions that provided education and clinical services to be part of a network for mental health professionals to support providers. Now, this is really such an undertaking, if I can look back at it. I often think how naive I was that we're just going to put this all together. And we did. I think it takes a little naivete to say you could accomplish really big, bold goals. And we have done that. But having these 12 different institutions that all have their own infrastructures, their own departments, their own presidents, all of those different things, and saying we're all going to work together to better the lives of Texans, and we're going to meet these metrics and these goals that the Texas legislature has set before us. And so in doing that, and I will say that even in other states, even in other large states or large geographic areas that are running access projects, I don't know of one that has 12 different entities working together. Now, Texas is like a country, right? We know that it's very, very large. But it takes quite a bit of support and organization to make sure we're all doing the same thing and to learn together and to utilize those lessons learned and to understand the differences in our regions. Because Texas is so big, we sometimes need a little bit different approach in different areas of the state, for engagement and telling people what we're doing and what kind of medical society is here and how do we get the word out in Houston differently from way West Texas in a rural area. What does that look like? And so we formed a centralized operations support hub, which is really I kind of think of it as the glue or maybe a spoken wheel structure. But having that be an overarching guide, like body of guidance of here are some standards, here are policies we want to work together, but we really have representation from all of these 12 health related institutions to help drive this initiative and this mission forward. It's quite phenomenal to watch it all happen. Dr. Laurel Williams, who I referenced earlier, is the medical director of our Child Psychiatry Access Network, and I have the privilege of being the medical director of the Perinatal Access Network. Next slide. So this is the great state of Texas. These are our regions. We broke down our regions across the state based on population, and then based a little bit on the catchment area of the university that exists there. So some of these regions are smaller in size, but much more densely populated. Some of these regions are much larger in size, as you see, but have smaller population centers or have lots of area where there's almost no population. And so thinking through how to staff each of our access centers or each of our hubs at the universities in a way that was equitable across the state and really grouped certain areas of the state together that are more alike. So you see this and you see all of the different institutions that are a part of this network across. And I think network is a great, MCPAP is the Massachusetts Child Psychiatry Access Project. And we are the Child Psychiatry Access Network. And I think that is really an apropos name when we think about how much we're networking together and we're working across the state to deliver these services. Next slide. So what are the goals of our access projects? They are to provide a network of support for youth and perinatal mental health, to support providers of youth and maternal health care to identify and manage their patients' mental health. So that's kind of the very first guiding principle. How do we support those people who are on the front lines in the clinical care of the youth and pregnant postpartum patients whom they are caring for? How do we expand in real time, right? They can call us in real time and do that. How do we expand access to education about youth and maternal mental health disease burden and effective treatments? Many of these things are new and emerging treatments. Some of them are not. They've been around a long time, but they weren't part of the training program of a pediatrician or a family medicine physician program or an obstetrician. And so they're being tasked, they know that all of their professional society say you need to screen, you need to intervene, you need to treat, but there's not the same level of residency education around mental health that there was, say, about asthma. And so they don't feel as confident in those standards of care. So we want to expand access to not just those clinician to clinician curbside discussions, but actual didactic education that you can come and learn and ask questions and hear a presentation and hear from an expert about the standards of care. We want to improve the mental health care and systems of care for youth and women who are pregnant and postpartum, suffering perinatal loss, or are planning pregnancy. In that way, we have referral teams, when we are able to help refer and we vet the resources and referrals that we're sending out. And so when we are able to understand like, hey, this resource actually doesn't exist, or it wasn't what they were looking for. It said it did this, but it didn't. Then we can cull and edit and perfect our resource and referral list and also understand what gaps exist. So gathering this data helps us better understand the landscape of mental health care for these populations across the state of Texas so that we can identify what additional steps we might need in what regions. And in that way, we want to improve the mental health care and systems of care for Texas children and adolescents and the women who care for them by engaging in collaborative care models that improve equity and access to care. So delivering care where people are, Not saying you have to, go across town to this large academic institution. You have to fight with the parking. You have to fight your way inside. You have to do all of these things. But let me bring care to where you are and take care of you. Next slide. So what are the core components of our access projects? I've talked about many of them over the course of this presentation, but we'll review them a little bit more succinctly here. One is that prompt phone-based consultation. When we talk about prompt phone-based consultation, someone will answer your call or get back to you within a very few minutes, if not immediately. That someone will be a mental health clinician or someone well-versed in the ability to triage that call to the right level of clinician. Is that somebody who, do you need resources and referral? Do you need some education sent over? Do you want to plan an educational activity? Do you want to talk to a psychiatrist about the care, or another mental health clinician about the care, your patient who's in your office right now? We want to receive, or we provide clinical guidance and assessment and treatment for presenting mental health symptoms. So we will talk to you immediately about, I say immediately, so that from the initial call may be immediate. Within 30 minutes, we have a child psychiatrist or a perinatal psychiatrist who will call back to talk with you about what's going on with your patient. But you can also schedule that for a different time that's more convenient for you. And so we can provide that clinical guidance and assessment. What are the appropriate screening instruments? What do you do when that screen is positive? How do you safety plan? And how do you help somebody if they are in a crisis? We're not a crisis service. We don't provide crisis intervention. We can help guide somebody and what they might need to do if they are concerned someone else is in a crisis. We also provide resource navigation and vetted referral services for patients with complex needs or substance use issues. This is what I was talking about with our resource and referral specialists who are constantly looking for additional resources and referrals, looking what is in the community, what is available online, what insurances are required, all of those different things so that we can actually provide, what is the wait list there? Is there a wait list? Calling and vetting those things so that we can provide a resource or to a referral to a resource that actually works and is the right level of care for the patient. And then training and education on mental health care for youth and the women who care for them. These are more didactic type interventions, more didactic webinars that we have, monthly echo series that we have, where we can have clinical case-based discussions and we can have an expert really talking about the standards of care on many different topics. These services are state funded. They are free to the clinician to use. The clinician's time, however, to initiate that consultation and to participate in that consultation is billable for reimbursement under many different code strategies. And so while the state of Texas is providing the funding for this service, the clinician can say, hey, I did a lot more care coordination to call this line and to provide this. And so I'm able to increase the complexity of that billing code and recoup some of that additional time that I utilized. Next slide. So these are some examples of webinars that we have done over time. So wanted to show you, we often have in our ECHO model, we do an intro to ECHO so that people understand, what are we doing? If you haven't heard of the ECHO model, it stands for Extensions for Community Health Outcomes. It was born out of the University of New Mexico with Dr. Sanjeev Arora, who had a terrible experience with a woman who was referred to him with end-stage liver disease. And he knew that if he had caught that earlier, she would have lived. And he said, we do not need to keep all of our knowledge in these ivory towers of academic institutions. We need to democratize this knowledge and push it out to where the patient is being seen and help someone screen them as soon as possible. The ECHO model does this through different than a hotline where someone's available right away, like an access project, but it provides in a more didactic teaching scenario where a clinical case is presented to a group of individuals and people weigh in on, experts weigh in, but also the clinicians delivering the care, the rural health clinician, the nursing staff that weigh in on what to do and what might work in different settings. And so here's just some topics that we have had for our both our child sessions and our perinatal echo sessions. And then we also have webinar topics that are much more instructional, not as interactive as an echo, but more what you think about as going and hearing a webinar, kind of what we're doing today. Someone's talking at you, you have a chance to ask questions, but it's not as interactive as the echo sessions can be, and not specific patient focused like those echoes can be. So you see this list of titles that we have done for webinars over time. There are links here as well if you'd like to sign up for our PeriPan webinar series or our Echo series. We would love for you to join us. They are free to join. They do have attached CEUs for them as well. So I think we want to provide as much education as possible to improve the understanding, destigmatization, early screening, and early intervention. Next slide. So talked about what we do, talk about what this is, but you can get one call to obtain clinician-to-clinician consultation and all of these people can call: pediatricians, pediatric nurse practitioners, family practice clinicians, OB-GYNs, psychiatrists. So you may say, I have a lot of expertise, but I've never seen a patient who wants to breastfeed and is on this specific medicine. I'd like to talk to a reproductive psychiatrist about that. Okay, great. Call us. No call is too small. We want to talk to you and help improve that capacity. We want to help improve your confidence and your patient's confidence in taking those next steps that are appropriate. You can speak immediately to a clinician who can assist with resources and referrals, and then have that call back from the psychiatry specialist, whether child or reproductive, within 30 minutes. Average time is less than 10 minutes. So it's pretty fast. But we also have a lot of clinicians saying, that we have a text line as well, so you can text in. We try to make it as easy as possible for people to access this resource, and so you can text in and say, "I'll be available at noon." We're like, "Okay, we'll schedule the call for noon." Next slide. So we now have access projects to fill gaps, build capacity, improve outcomes, reduce stigma, to support the mental health of our youth and perinatal women. And it has been a journey, like I said, to build an access project across the state as big as Texas. There are people who still don't know we exist when we think we talk about this from sunup till sundown to anyone who will listen. There are still people who have heard of it but aren't quite sure what it does and what to do. So we want to tell people that the Texas legislature and these institutions have come together to provide an access project to do all of these things to support the mental health care access and treatment, early intervention, and appropriate intervention for the youth and peripartum women in Texas. Next slide. So our last was to identify barrier. I think we have two more goals actually, but the goal 5 was to identify barriers to mental health assessment and treatment in your clinical setting. Next slide. So I want to talk a little bit about potential barriers that we see when we talk to people about this project. We say, okay, call us. And they say, have you ever come to my clinic before? And I laugh because I get lots more time than many people do with their patients as a child psychiatrist and a reproductive psychiatrist. But when I start my clinic day, I'm running from thing to thing to thing. And so I say, yeah, it is a barrier when you're like, when do I call? When do I do this? How do I use this? How do I logistically use it, even if I think it's a good idea? And so we hear things like, I have limited experience in assessing for mental health disorders. We're like, great, we got you. You don't have to have any experience in doing this, which many clinicians have plenty of experience. They just don't have confidence, or they have plenty of knowledge base. They don't have confidence in doing it. So we want to help support them in that. No call is too small. We are happy to answer any range of questions about assessment, intervention. Should I assess? What things should I be looking for? Anything like that for both these first two barriers of the feeling of limited experience and low confidence in assessing and treating mental health disorders. These last two are more environment driven instead of personally driven by that clinician. But the idea that the clinic doesn't support me in providing mental health care. We know that in some places they say, we want you to see these patients as quickly as possible. You need to get them out the door. You don't have time to do these more complex visits. And that can be hard. That can be hard if you don't feel like you have the time to address the things that you need to do for that patient. We want to actually help you in that. So if you say, I was only able to give them the screener, I sent them out the door, I told them I'd call them later, I'd ask my nurse to call them later. Great, call us. We'll talk through what kind of guidance to give that family with that screener. Or you say, hey, I saw this patient earlier. I had to move on to my other patients, but I'm really worried about them and I don't know what to do. And this is what I did with them. Great, let's have a discussion about it. And so it would be lovely if we were all reimbursed appropriately for the mental health care that we provide and the extra time that it takes. And I think that's a journey that we're going to be on for a long time with the illusion of parity for mental health care reimbursement. But we want to support you even, and so you don't have to call and say, I know all of the things, I was able to do all of the things in this patient visit, but we concerns and how can I support you in the environment in which you're in. And then we have clinics that don't routinely screen for mental health disorders. So I'm doing all of these things. I don't know if they have this. I don't know when to give them a screener. And we can walk you through that. How you screen, what are those pain points? We have toolkits. We have information that says, here's a screening packet. You can just print out and hand to the patient. You don't have to recreate all of these things. We also, if you're like, I've looked at all your materials, they're great, but I really need something else that does this, call us. You are not the only clinician who might need this. We want to help provide that resource to you. If it helps you increase your capacity and increase assessment and intervention, early intervention in your clinic, we want to help you provide that. We want to help create that resource for you. Next slide. So there are many barriers. CPAN and PeriPan teams want to help. We are not totally Pollyanna and naive, although, that's my baseline. We do understand that there are difficulties in implementing these things, and we want to help you. And if there are things we haven't thought of, we want your collaboration in helping better understand that. Next slide. So goal 6 is really to think through how to use CPAN and PeriPan. And I think this is a very diverse audience with people coming to this seminar and to this conference from probably many different clinical backgrounds and personal backgrounds, and some without clinical backgrounds, just their own personal clinical experience. And so this may be variable for many people, but thinking through, how do we develop plans for utilizing the resources that CPAN and PeriPan are creating and advocating for these programs in Texas? Next slide. So the first thing is if you are a clinician, you are a frontline clinician, we want you to enroll. We want you to enroll right now. Here's you can call this phone number and enroll. We want you to say, yes, I want this service. We've talked about that enrolling sometimes is a scary word for people. They feel like, what does that mean? What do I have to do? What kind of personal information? Is it just my firstborn, or is it also my firstborn and my social security number? Or like, what do you need from me to enroll in this program? And enroll is really a word that we just use so that we see who we've engaged and who we haven't. Sign up may be a better word for this, because there's some information that we need just so that we can call you back and talk to you about patients and make sure that we have, that we can document about your patient, but it's not there's nothing else for you to do. So I want to decrease the pressure around that enrolled language. And, what we want you to think through when I give this case in person or on a more interactive setting, we want people to think through, do you have a patient with mental health concern right now that you're thinking, this would be really helpful. It'd be great if I could call somebody about this right now. And then we do want to think about screening protocols. So I talked earlier about one of those barriers is, well, my clinic doesn't even screen routinely for these things. It is standard of care across every professional organization of which I'm aware, across every discipline that is in primary care, to screen for mental health conditions. And so there's no discipline where it's not standard of care. We want to make sure we are screening. We want to help you develop screening protocols for your clinic, because when we screen and we identify early, we can intervene early. So often we're waiting to screen until someone tells us they're anxious, someone tells us they're depressed. By the time they tell us, they typically have been suffering with this severely for quite a long time. Then they tell us, we screen them. They have a very high score. We freak out. We don't know what to do. We think they need the highest level of care, and they may at that point. But think about if we routinely screened, just like we got a blood pressure routinely or a pulse routinely, thinking about how much of the population this affects, more than hypertension, more than tachycardia, probably. So thinking through if we made this as a vital sign, and we made this as routine as getting vital signs, then we might find people with much lower scores on their screen. And we destigmatize that we're screening at all. We're not screening you because we're worried about you going home with your baby. We're screening because this is a part of healthcare, and we want to make sure we're supporting you. So we can, when we screen routinely, we identify things earlier, not to over pathologize things, but to intervene earlier, because we can intervene less. If I don't need to give you a medication for something and I need to instead to send you a support group at the same evidence level because it's a lower screen, great. Wonderful. I don't want to wait until you're very high screen and very affected and must have much more intensive intervention. We don't have time for that. We're moms. We got to move on. We got lots of stuff to do. And then, thinking through when developing that workflow that includes contacting CPAN and PeriPAN when you have patients where we can support you, basically, for all of these reasons. Has a chief complaint of behavioral, mental, or substance use, screens positive on a screening protocol, you've started a treatment, but they're not improving, you're not sure what to do. Patient is in treatment with other mental health providers, and you or the patient or family is concerned that they're not having significant improvement. So all totally appropriate to call PeriPAN about. Next slide. Our children deserve it. Our moms deserve it. You deserve it. And together we can do this. And I'll just say one more thing, because there is another service that we provide in here that I didn't really outline. I would like to, unless it's on the next slide, is that we also can see people as a one-time telehealth consult, where we can have a conversation and say, I'm not sure what's going on. I don't know. And we can, for free, see that family, see that mom, see that kiddo, with a specialist in the area, reproductive or child psychiatrist, to clarify that diagnosis and clarify the treatment plan and say, what are the next right steps, so that we all feel a lot better about that. Next slide. This is a quote from a pediatrician, I believe, that I think is really helpful. I'll just read it. CPAN is a great asset to me. The intake coordinators are extremely knowledgeable and help me in providing the best care for my patients. The child and adolescent psychiatrists are helpful in advising medication therapy and other treatment modalities or evaluations needed. Having limited resources here in East Texas makes CPAN a necessary part of my treatment strategy for kids. Next slide. And this is from a perinatal provider. Mental health services are in desperate need. The PeriPAN program allows me to take excellent care of my pregnant and recently delivered patients. I know I will get good advice with a fast phone call, and I don't have to wait and hope a patient calls their insurance and finds a provider that is accepting new patients in a timely manner. Next slide. So these are our references. I'm happy to answer some questions. Thank you for listening, and I hope that if you have the opportunity to be a clinician who has not enrolled in PeriPAN or CPAN, that you call that number and get enrolled. This is our website. I encourage you to go there, whether you're a clinician or a patient, mom, a spouse. We have patient-facing materials on this website. We will get more. We have our webinars listed here so that you can watch them. We want to, our goal is, as a state, that we improve our general consensus knowledge around mental health distress and how we can support each other. Thank you.
Thank you, Dr. Wakefield. That was really, really enlightening. I had no idea how much work you guys were doing. It's very impressive. I imagine it probably feels a little bit like moving a mountain. Um, but thank you for sharing that with me. I noticed a couple of things that you said that kind of stood out to me. I love no call is too small. I think maybe you need to trademark that.
Well,
And
I'll give that. We have a great team with our Center for Healthcare Communications, and I don't know that she coined it or she took it from a meeting we had, but every time I hear that, I hear Melanie Susswine saying, "No call is too small." So it is definitely a team effort. I would never, I think, and you just saw Jen Erdige's information up there too. I could never ever take credit for all of this work that's going on. It is all of us pushing our marbles to the middle and working together because this is such an imperative for the state of Texas, and we believe in the state of Texas.
yes, I couldn't agree more. As a also native Texan, it's really important to us here at Handlehold that we talk more about mental health, especially in that peripartum section of life. And you said our moms deserve it, our children deserve it, and I think that is very well said. Um, well, enough about what I thought. We have a couple of questions that I wanted to bring to you that have come up in our question and answer. So the first one that kind of stood out to me was, what guidelines do you suggest for how to approach doing mental health assessments or screenings to create a safe place for people to answer honestly?
Yeah, I think that's great. It's a phenomenal question, and I think it will vary maybe in the population that you have and in how routinely you do it. I have implemented assessment protocols in multiple different clinical settings, and I can tell you at the beginning, everybody feels nervous about it, right? So some of implementing anything new is just pushing through the nervous feeling of like, how is this going to go? I don't know. And I've learned a lot from patients when they say, "Hey, I would like to fill this out in a different area," or like, "I would like to fill this out." They typically love filling it out on like an electronic pad because it can go quickly and it goes away, right? They're not holding all these papers where they're like, "Whoa, I filled out all this information," and kind of looking at it. But I would say start where you are and do something because it is the standard of care. And I think being thoughtful is great about where you're doing it, and in what order you're doing it. I will tell you that a patient's mom taught me a great lesson in the latest clinic where I implemented screening. And I had done it multiple other places. And I got this notification like, patient's mom doesn't want the kiddo to fill out the screening. And I thought, oh, what is happening? So I went and talked with mom, and the order that they were assigned from our new electronic health record were in an order that I could imagine would make me as a mom feel really like they started as the most severe one instead of being predicated on each other and like having, hey, if this is positive, it would move to this one. It started with the most severe one because it had been like tasked alphabetically. And I didn't know that. I just said I need them to have these. And so I was like, oh my gosh, yes, of course that makes sense. You don't want that to be the first question that they see. Because she was like, if it could not be the first question, I was like, yeah, absolutely, that makes sense. So she, I didn't even think to know that that might happen because it hadn't happened in the other systems in which I was in. So I think, knowing that it's not going to go perfectly and learning from that and getting that information. And sometimes people are going to be mad and they're not going to fill out any of it, but you can say, I have an entirely different talk on measurement-based care. And so I'm not going to, I can't do all of that here. But what is very clear, and this is what we call measurement-based care, like using a screener and then doing an intervention and doing the screener again and seeing if they got better, like we do in all of other healthcare, but we just forgot to do it in mental health care. So when we use measurement-based care, it actually improves patient satisfaction. It improves their time to getting better. It gives them more of a voice in what's going on, and so you can review it with them. So there's a lot of great evidence around using, and actually so often I hear, well, patients don't want to fill out that many screeners. Actually, the evidence is the opposite. The more screeners you use and the more you review them and bring them into the care, the better the patient feels about the care that's being delivered. right? Because they come in and they're like, what voodoo magic are you doing picking some medicine that you're doing? You're just talking to me. And so the more that you can tell them, like, we're following these things over time and you're telling me what is happening, the more they feel engaged and like, we're not just, they're not guinea. I mean, I can't tell you how many times over my career someone has said, I just feel like a guinea pig. And instead, I can say, no, look at the trends of your scale. We're changing this medicine because you're not getting better on this medicine, right? Like I'm not randomly throwing things at the wall. Like we're looking at this. And so utilizing those screeners, I think first you have to be confident in the evidence of using them. And then you have to be thoughtful about how you're using them and where you're giving them. We don't want it to extend the appointment time. We want to give it in a way that uses that downtime in the appointment, where they're already waiting there, or they're waiting on vital signs if you're in a medical clinic, or there can be links that you send them ahead of time, those kinds of things. And you don't want to use measures that you don't need. I said the evidence says if you use more and more, and that is true, it's true, but you want them to be pertinent. You want to use them in that decision making.
Sure, that makes perfect sense. I think myself have filled out many screeners over the years. Think about just like a well visit for your child. You expect it, you know that it's going to come. And so you don't have any thoughts about like, I need to know how many vegetables a day they're eating, right? Like it's sort of the same thing. So
yeah. It's totally the same thing. We just forgot to do it for mental health care. Like we do it for other things and it's fine. We just forgot to do it for mental health care.
Well, we're on the path to making it right. Another question that came up was if you could talk a little bit about how the consultation line for mom differs from PSIs. And I'm not super familiar with PSI, and I also saw that some other people were not in the chat. So maybe if you have any kind of.
Absolutely. So first of all, Postpartum Support International is a phenomenal resource, and we should all use it as much as possible. They have lots of different things on there. And so my favorite, I shouldn't say my favorite part because that'll probably get me in trouble. Lots of wonderful, one of my favorite things about PSI are their online support groups. And so you can go on there and for free find all kinds of support groups. And I will tell you what's interesting is just a educational support program. It was a specific one. It was called Rose, but a specific educational support program for women in the postpartum period decreased postpartum depression by like half. Like, okay, yeah. Turns out we're designed to live in tribes and have other women and other moms and other people have been through it talk to us about what's normal, what's not, and validate our feelings and all of those things. And we don't. We get a baby and we take it home by ourselves in a house, and then we put cute pictures on Instagram and we pretend that it's all really a pretty process while we're like bleeding and lactating and all of these different things. So I think first, support groups are really important. Support networks, like community, all of those things. And so the less that you have that physically, with you, the more you need that. You have to create it. You have to create your tribe. Another thing, right? Well, more on the list, but it's probably the most important. So PSI has a huge list of free support groups, and they are very specialized. So when you look at them, you can find your tribe. You can find your people who've had a similar experience to you. It's like there's a pregnancy after loss, there's a dad's, there are all these different support groups. And because it's international, Postpartum Support International, you can find, it's like a good cohort of people who have a similar, I might not be able to find all the people with a similar experience in my town, right? But you can do that. So PSI is phenomenal. They do a conference every year. It's amazing. And they have for a long time supported a PSI support line. They also, I'll tell you the other thing they're doing that's really, really important. They actually have two lines. One is not, I don't think branded as PSI, but they're working with HRSA on it. And that's the maternal mental health support line. And that is patient facing. And so that we want everybody to know about. That is for moms to call, to have somebody who is trained in reproductive mental health, trained in postpartum health, to talk to them, to say, hey, mama, you feeling in crisis? Here's what's going on. How can I talk to you about this? So that maternal mental health hotline is something we want to give all moms, and that's a PSI partnership with HRSA. There's an additional line that PSI has had that I think this person is referencing for a long time that is clinician facing. And that is the differences in it is that's a volunteer line. So you call as a clinician, you say, hey, this is what's going on with my patient. And some volunteer, amazing reproductive mental health volunteer gets back to you when they can. Okay. So that can be days. It can be, it can be a delayed time period. So PSI has on their website all of the states that have access projects, and they want you, if your state has an access project, they want you to use the access project and reserve the PSI line for those states that don't have an access project. Right. And so that's really, it's not a dissimilar idea. It's that it's not funded. It's volunteer driven. And we, if states have done the right thing and taken the lead from PSI and from Pat for Moms and all of those things, then call that line, because that's what they're tasked to do from their state, is to deliver this service.
Okay, that's super helpful. And just clarify a little bit for us, kind of how your approach is different from PSI's, or would you say that they're very similar?
I mean, I think that PSI, like they're complementary when you think about the different, we recommend PSI services all the time. I was just working on a pocket card earlier today, and PSI is on there as a resource with a QR code to the group. So there's not, we don't, like PSI provides those groups. We don't provide direct services other than that telehealth assessment. We are really there to help increase the capacity of that frontline clinician. But we will advocate for PSI resources all day long. And like I said, that PSI support line, or that clinician focused line, exists for those states that don't have an access project.
And that leads us right into another question that came up is, could you clarify, are CPAN and PeriPAN only available in Texas?
So they are, because they are Texas focused projects, but you can, I don't have it on me, but Jen could probably put it. I know she's listening and she's like a wizard, but, there, I don't know if she can drop it in the chat, but there are, you can like go to so there are, I think 30 states that have perinatal projects now, and more than that have child projects now. So definitely the majority of states in the nation now have an access project. That's fairly new. I mean, that's the last 3 to 5 years happening. And so that's not something, that was the case a decade ago. But it is the case now that more states than not have both perinatal and child projects.
Okay. Thank you for clarifying that. Let's see if we have any other questions that have come in. I think you've answered most of these. Yeah, I think you got all of those questions answered. That was really super helpful. Thank you very much for just spending the time with us. Is there any closing remarks that you want to say before I close us out for the day?
Oh, I think I just put it in the chat for I really appreciate all of the kudos, but it really is my privilege to do it. It also is sometimes woeful to do it too. Like these are just things we should have done a long time ago. We want to take care of our community. We want to build community. I think we can do that in lots of different ways. I really do think it takes us all, that not any one thing that we do is going to be the linchpin, but that we can all work together to improve the access, the decrease the stigma, and improve care in Texas for our moms.
Well, thank you, Dr. Wakefield. And thank you to all of you who joined us today. Today was full of valuable insights, best practices, and a reminder of the need to continue to elevate and champion NICU parent mental health and support. I hope everyone takes time to reflect and recharge tonight in preparation for day 2 tomorrow. Please refer to the agenda for tomorrow's schedule. We will begin at 10:45 a.m. Central Standard Time, and we can't wait to see you again. Have a great night, everyone.